concluded. Good morning, everyone. My name is Adewale Okundare. I'm taking the West Africa March 2024 practice question 1A. Question states, 18-year-old senior secondary school, 2 students presents with woody edema of the lower limb without scrotal involvement. His mother says he sometimes has discharge with healing after scaling of the skin. There's associated hyperpigmentation and lichenification. So a picture is shown below. Is a picture showing gross swelling of both lower limbs, maybe with some skin scoriations around the toes. So the questions are as follows. What is the diagnosis? The diagnosis here is lymphatic filariasis. 1, because this is sub-Saharan Africa. 2, because there is gross edema of both lower limbs, which is suggestive of lymphedema, which is how lymphatic filariasis would commonly present. Question 2 is, how will you make a quick diagnosis? So I think this is a bit tricky because of the question that followed, which is, what time will you take the sample to improve possibility of making the diagnosis? For the commonest organism for lymphatic filariasis in sub-Saharan Africa, which Nigeria is inclusive, the organism will be Wuchereria bancrofti. The standard of testing for Wuchereria bancrofti now is by a point of care test, which would give you your results in a couple of minutes. That's the circulating filaria antigen test. But because of the subsequent question that followed, which is, what time will you take the sample? The circulating filaria antigen test does not require you taking the blood sample or plasma at any point in time, because what it checks is the antigen of the filaria organism, as against the traditional method of diagnosis of lymphatic filariasis, which is by demonstration of the organisms in a peripheral blood film. And because the organisms, as well as the vectors, which are mosquitoes, exhibit circadian periodicity, both the activity of the worms as well as the activity of the vectors, the peak feeding period is between 10 p.m. to 2 a.m. So it's advisable to take the samples between 10 p.m. to 2 a.m. to have the highest possibility of making a diagnosis if you're doing a peripheral blood film. Number 3 question states that, what is the most common causative organism in West Africa, which is Wuchereria bancrofti? Number 4 states, what additional diagnostic tests can be done? So I've already mentioned the circulating filaria antigens, if that's what I wanted to hear in question number 3, or peripheral blood film. Polymerase chain reaction can be done, but it's not widely available and it's mostly used in research. We can also do serology testing, which tests for the IgG or IG4 antibodies against the organism. But one of the shortcomings of this is that it can differentiate between an old and a present infection. Also, we can also use imaging to actually see the adult worms via the use of ultrasound or lymphoscintigraphy, that you can actually demonstrate the worms within the lymphatic vessels. Question 5 states, what's the role of doxycycline in the management of this condition? The organism, most filaria worms, tends to coexist with a rickettsia-like bacteria, which is called Wolbachia. It's an endosymbiotic bacteria. Its responsible for normal development and fertility of the filaria worms. And also in the pathophysiology, immune response against this bacteria is said to contribute to the morbidity that is associated with lymphatic filariasis. So the doxycycline targets this bacteria. It's also been said to improve mild to moderate lymphedema, regardless of the status of ongoing infection. That is, even when they are negative for circulating filarial antigen. It's been shown on its own to reduce the size of mild to moderate lymphedema. And then thirdly, it also has microfilariacidal activity. So that means it can actually kill off the adult worms, contributing to eradication of the organism in the body. So that's the end of the question. I have a few slides on lymphatic filariasis. So filariasis is caused by nematodes or roundworms that inhabit both the lymphatics and subcutaneous tissues, and then humans are the definitive hosts. There are 3 species of lymphatic filariasis: Wuchereria bancrofti, Brugia malayi, and Timori. More than 90% of lymphatic filariasis is due to Wuchereria bancrofti, and the remainder is due to Brugia malayi. Brugia Timori seems to be isolated to the Timor Islands in Indonesia. And the disease is spread from person to person through mosquito bites. Bancrofti is not just limited to sub-Saharan Africa. It's also found in Southeast Asia, the Indian subcontinent, Pacific Islands, and focal areas of Latin America and the Caribbean. While Brugia malayi is mainly seen in China, India, Malaysia, the Philippines, Indonesia, and various Pacific Islands. It affects approximately 120 million people worldwide, and it accounts for over 5 million disability-adjusted life years, and over 40 million individuals are affected by the disfiguring features of the disease, including mental illness, in which depression is actually very common. Both sexes are equally susceptible to filariasis. Infection is likely first acquired in childhood, with approximately 1/3 of children in endemic areas said to be asymptomatically infected before the age of 5. And a prolonged stay in an endemic area is usually required for acquisition of the infection because the vector is actually inefficient in transmitting the disease. And then because the life cycle is in both the intermediate host of the mosquitoes now and the humans, who are the definitive host, you need constant or prolonged exposure to the worms organism to be able to develop an infection to it. So if someone who resides in an endemic area leaves that area before acquiring a significant amount of the worm load required to cause disease, then the person might not eventually develop the disease. So the mosquito vectors vary geographically. The vectors for Wuchereria include the Culex, Anopheles, Aedes, Mansonia. Vectors for Brugia are typically Mansonia and Aedes. So this is just an image depicting or showing the life cycle of Wuchereria bancrofti, similar to what you find in almost all the filarial worms. There are 3 stages in human and 2 stages in the intermediate host, which is the mosquito. So the first stage larvae or microfilaria is picked up during a blood meal by the mosquito, and it develops into the second stage as well as the 3rd stage within the mosquitoes. And then during another blood meal, the 3rd stage larva is introduced via the broken skin, and then it migrates through the subcutaneous tissue and enters into the lymphatics in the humans, and where it develops into the adult worm. The process of development into the adult worm takes about 9 months, in humans. So there's reproduction with the adult female worm producing thousands of microfilaria, which is also the first stage larva, and then the cycle continues like that. So the mosquito picks up the first stage larva. In the mosquito, it develops into the second stage, the third stage larva, reintroduced into humans, develop into adult worms, produce thousands of microfilaria, and picked up over and over again. So just a brief pathophysiology of lymphatic filariasis. Like I said, the adult worms replicate in a definitive host. There are 5 stages, which I've talked about. The most commonly affected lymph nodes are the femoral and epitrochlear, and there's usually an immune response to the presence of the antigens of the worms, not the worms themselves, with cellular infiltration with plasma cells, eosinophils, and macrophages, with hyperplasia of the lymphatic epithelium following repeated episodes of inflammation. And what this does is that it results in lymphatic damage and leakage of protein-rich lymph into the tissues, with accompanied thickening and varicose changes of the skin and chronic bacterial and fungal infections. All of this contributes to the final picture that we see in the patient with lymphatic filariasis. And there is also immune response directed to the endosymbiotic rickettsial-like bacteria or Bacchia. What are the clinical features? This includes features such as fever, inguinal or axillary adenopathy, testicular inguinal pain, skin exfoliation, and then chronic features would include genital swelling due to hydrocele, elephantiasis of the legs, scrotum, vulva, breast. Can also have chyluria, can have hematuria, proteinuria, or even the development of chronic kidney disease in these individuals. So it can present with 4 different types of acute syndromes. First is acute adenolymphangitis, which is simply sudden onset fever with painful lymphadenopathy. And this is said to be because of immune-mediated responses to dying adult worms. The second one is acute dermatolymphangioadenitis. It's characterized by edematous inflammatory plaques and systemic symptoms, which includes fever, chills, myalgia, headache, and is said to be due to superficial bacterial infection of damaged skin. Filarial fever, which is characterized by recurrent episodes of self-limited fever, often in the absence of lymphangitis or lymphadenopathy. And the fourth one is tropical pulmonary eosinophilia. This presents with dry cough most of the time. The cough is said to be nocturnal in nature. There might be dyspnea, anorexia, malaise. When it persists, there can be weight loss. Patients may or may not be characterized by presence of transient infiltrates in the lungs, and it's due to the immune hyperresponsiveness to the microfilaria that is trapped in the vasculature of the lungs. It's characterized by peripheral eosinophilia as well. How do we make a diagnosis of lymphatic filariasis? Diagnosis requires demonstration of microfilaria in the peripheral blood, especially for the Bruggian species. The circulating filaria antigens, like I said, has almost become the standard for diagnosis of Wuchereria bancrofti, but it does not pick up the Bruggian worms. It's a point of care test and can detect the antigen either in blood, serum, or plasma. So this can be done anywhere, can be done by the patient's bedside, and it's quick, you get the results almost immediately. I've mentioned the others earlier. So on full blood count, like I said, eosinophilia said to sometimes greater than 3,000 cells per microliter, and it can also have elevated serum hemoglobin E. Moving on to treatment, the drug of choice for lymphatic filariasis is diethyl carbamazine. However, we have to be careful when there's co-infection with onchocerciasis as well as loasis, in which case there can be development of sometimes very serious or fatal encephalopathy. When this medication is administered, when there's a high density or high population of or one burden of onchocerc. either Onchocerca volvulus or Loa Loa. But if the person has a mono-infection, then the drug of choice is diatic carbamazine given at 6 milligrams per kg. There are two regimens, either you give it as a single dose or you give it for 12 consecutive days. And so the addition of doxycycline, like we said, to target the Wolbachia, that's the endosymbiotic Rickettsia-like bacteria, it's also appropriate because of the macrofilariacidal activity and also because of its effects, the most treated effects on reducing mild to moderate lymphedema. So if we have co-infection with Onchocerca, it's advisable that we treat with ivermectin first before we go ahead to treat with diatic carbamazine for the lymphatic filariasis. An alternative therapy to that is to use doxycycline followed by ivermectin, which is a reasonable treatment for both infections. For Loa Loa, it's a bit staged. Said if the burden of the organism is less than 2,500 microfilariae per mil of blood, then diatic carbamazine therapy can be used. But if it's less than 20,000, ivermectin pretreatment can be used to reduce the microfilarial load prior to administration of diatic carbamazine. But when it is greater than 20,000 microfilariae per mil, it should be treated with doxycycline for 4 to 6 weeks, which has no effect on Loa Loa, but has an effect on the lymphatic filarial worm. Albendazole is an alternative which can also be used in patients who cannot tolerate doxycycline and when the Loa Loa load is greater than 20,000 microfilariae per mil. So this can be used as a dose of 200 to 400 milligrams with fatty milk twice daily for 21 days. What are the other forms of supportive treatments that the patients will benefit from because of the lymphedema that they have? So it's been said that they should exercise, they should mobilize, and the limbs should be elevated at night, and there should be application of compression bandage support for the limbs. And then also they should keep the limb clean, apply antiseptic creams such as mupirocin cream to open skin abrasions, and they should be advised to wear comfortable footwear. There can also be indications for surgery, although there was no scrotal involvement in these index patients, when they have light hydrocele and scrotal lymphatic. And surgery are said to not have a favorable outcome when it comes to gross limb lymphatic. It's less successful, and then you have to have multiple procedures, including skin grafting. And like I said, because of the disfiguring nature of the illness, there is a high prevalence of mental illness in individuals who suffer from this condition, and then psychotherapy may also be required in these individuals. How do we prevent the disease? One of the focus of WHO in eradicating lymphatic filariasis is mass drug administration programs, which has been said to be successful in some countries of the world. The vector control can also be done. So with mass administration, what they do is simply to administer diatic carbamazine to people who live in endemic areas. But you have to be sure, like I said, that there's no co-infection with either filariasis or Loa Loa. Vector control can be done with use of insecticide-treated nets in areas where it's endemic and where we have anopheline mosquitoes that transmit the parasites. Also use of personal protective measures like mosquito repellent creams and the rest. Thank you very much for listening.
Thank you, Dr. Adewale, for this lucid presentation. It's actually a very good one. Thank you once again. It's time to entertain contributions. So any contribution, please? Maybe before I can start with my own. My own is just a question. It's actually a very good one. I don't know, since during treatment, one has to keep an eye whether there is co-infection with lower or onchocerciasis. So I don't know, is it a recommendation that during investigation for this kind of patient, you go along with investigating along for lower or onchocerciasis, or how will you know there is coexistence of infection with those so that you will not give diethyl carbamazepine death? Thank you.
Okay. Thank you very much, for the question. Yes. Okay, I think starting from the clinical presentation, both onchocerciasis and lower are majorly skin filarial ones, so they will manifest more with skin lesions. Lower also called calabar swelling causes transient subcutaneous swellings, which can be recurrent, and they also have eye involvement. So I think all these patients should be screened for eye pathology. Sometimes I think the ones can even be seen in the eye, and then they would have more florid skin lesions, which skin snips can be taken, and you can actually demonstrate these other organisms in them. So I think it shouldn't be out of place, one, using clinical features to either rule them in or out, and then two, to actually evaluate for them side by side. Because like I said, mostly there will be skin manifestations in them. I hope that helps.
Thank you. Yes. I don't know, somebody's raising his hand. Please go ahead, sir. I can't see the name, sorry.
Okay, thank you very much. It's a very good presentation. Mostly for this lower and onchocerciasis is based on epidemiology. Are you treating lymphatic filariasis in an endemic area with in lower or onchocerciasis endemic area? That is among the best catch. What to use? Is it ivermectin or diethyl carbamazepine? So caution is mainly taken in treatment of lymphatic filariasis in endemic area of Lao or onchocerciasis. But you can also see if there are clinical features, or you can investigate. That is not out of place. And in addition, because of the longevity of Wuchereria bankrupt, you have to, the mechanism of the drug action is to mobilize microfilaria for the immune system to kill the young microfilaria. So that is the main mechanism of action, but the drug doesn't usually target much of the adult womb. So that is why there is need of repeated doses in relation to the longevity of the adult womb. So I think, if I can really remember, is it 3 monthly or 3 to 6 monthly for 6 years or what? I have forgotten, but it's not a single dose, because the mechanism is to mainly mobilize the lymphatic, the microfilaria for the immune system to kill them. But the adult womb has long longevity in years, so there is need for repeated doses. I have forgotten for which period and the frequency, but I think it's 3 monthly or what for 6 years. But we should check it up and see. Thank you very much.
Thank you very much for the contribution.
Thank you, sir, for the addition. Dr. Success is raising her hand. She wants to contribute more. Go ahead, ma'am. Hello, Dr. Success. Go ahead, please.
All right.
Okay.
Okay, good morning, ma'am. Thank you so much, the presenter, for that lucid presentation. Please go to the next slide. The next one, please. Okay, thank you. That's STEM 2. How will you make a quick diagnosis? I think that one was, how will you make a which bedside test can you do, okay, to make the diagnosis? And I think you are correct. But what I said was, I will do thick and thin, blood film, and they let me go. Now, the next question of, I understand where your confusion came from. So when are you going to collect the samples? Okay. So what I said was samples should be taken at night. And they also gave me my score. Because when you put 2 a.m., 2 a.m. is morning. 2 a.m. is early morning. And in as much as possible, you need to avoid anything that will be conflicting in your answers. So they won't keep you there while time is going. Okay, so the samples are best taken at night. Yeah. So that's what I just wanted to comment. Thank you.
Thank you, Dr. Success, for this very good addition. Thank you.
Thank you.
There is also a hand raised by Dr. Orimolade. Go ahead.
Yes, thank you. Thank you so much. Thank you, Dr. Ogundari. That was a very, very lucid and brilliant presentation. So one of my points has been raised by Dr. Success. It's better to just see at night. That was what I said, and I was just let go. The timing was not important. Then another thing was, as part of the questions that were asked for subsequent answering or recall, so that we don't miss it, they asked for the acute syndromes. We asked to mention 2 acute syndromes. Sure. So the 4 that you mentioned, we should just take note of that, the acute syndromes and how they come about then. Thank you so much.
Thank you. Well done. Thank you for the addition. Dr. Dalhat also wants to contribute again. Go ahead, Dr. Dalhat.
Okay, thank you very much for the presentation. With regard to co-infection with lower and lymphatic filariasis, you are saying the ivermectin. I think even ivermectin causes similar effects as that of DEC. So the best treatment of choice in that case is actually albendazole. A long use of albendazole, not ivermectin, actually. Thank you.
Thank you, Dr. Dalhat, for the addition. I don't know. There is still, I'm seeing hands still. Dr. Tanimu, is it the previous hand you raised or is the new one?
In addition, if they are going for specific time, because my own examiner said which hour. So the usual hour is 9 p.m. to 3 a.m. That is the period. If they want to go specific. But if you say at night and they accept, it's by and large very good. Thank you very much.
Thank you, sir. Thank you, all the contributors. I think let's read out from the chat box. Dr. Precious is saying, thank you for the excellent presentation. Similar to what Dr. Odanye said. And Dr. Olalekon said, thank you for the lucid presentation. What are the likely differential diagnoses of lymphatic filariasis? So he wants you to mention some of the differentials.
Okay, thank you very much for the question. So the differentials would include onchocerciasis, like we mentioned, loa or loasis. We can also have differentials of lymphedema itself. This can include malignancy, primary lymphedema syndromes that are due to genetic defects. We can also have bacterial lymphangitis. These are possible differentials of lymphedema.
Thank you. Well done, Dr. Adewan.
Yeah, thank you.
Again, Dr. Feishara came, they said, good morning. He also mentioned at night, but they asked him for specific time. And I think Dr. Tanimu has clarified that we can see anything from 9 p.m. to 3 a.m. Then Dr. Mamodu said, black witches fly at night, Brugia and Wuchereria. Then Dr. Omodele said, they asked me for a specific time too. So I think we should be conscious of the time again. So I think those are the things from the chat. I don't know whether we have one or more things before we go to the next presentation.
Sorry, please, I have a contribution. Good morning, my teachers. Good morning.
Good morning, ma'am.
Okay, I just want to add that podoconiosis is a very close differential of elephantiasis, that's from lymphatic filariasis, because both of them look alike. Like if you see the pictures of patients that have podoconiosis, it looks just like lymphatic filariasis, and both of them also have acute syndromes. And it's like the second most common cause of tropical lymphedema. So I think after mentioning lymphatic filariasis, if you're asked for differentials, I think you should mention podoconiosis as part of your differentials. Thank you.
Thank you, ma'am. But ma, what please causes that podoconiosis, please? Sorry.
It's kind of like a non-filarial cause of elephantiasis due to exposure to intact soil.
Okay, okay. Thank you very much. I think we can, the second presenter can start sharing the slides.
Another differential is lymphedema tarda and lymphedema precox. So they present as lymphedema. So when you are taking for the differential, you have to say the differential that causes lymphedema. So among them, as she said, podoconiosis, lymphedema tarda, and lymphedema precox.
Thank you, sir, for this wonderful addition again, sir. We thank everybody that contributes. I think the second presenter should start sharing the screen. Yeah. It could be Dr. Abu, Ifeanyi, or Dr. Adewale could go ahead and present his question number 4.
Okay, I'm here. Dr. Abu is here.
Okay, Dr. Abu.
Good morning, Dr. Good morning, Dr. Mohammed. How are you now? This is Dr. Shiti.
Good morning, sir. Good morning, sir.
Good morning. Yes.
Go ahead, sir.
Yes, I think, yes, the differentials, I agree with Dr. Kanimo on those differentials, but you can simply say congenital idiopathic lymphedema, and that covers the lymphedema, precox, the tarda, and the rest. Okay, that too is a good differential since it was a child that they were dealing with. So that would be a very good differential. Then for the time of taking the samples, well, I don't think, I suspect that people here have not been taking these samples as residents. And it's one of the things you signed in your book. Okay. Blood smear for microfilaria and things like that. I believe it's still in the logbook. Okay. So in our days, though, way back in the day, okay, we actually, my area, we actually have those people with those microfilaria worms, infections, and all this stuff we talked about this morning. So we used to take the samples at 10 p.m. That's what they want to see. That's what they want to hear. So just say 10 p.m. Okay. Hey, you arrange to take the samples by, just give them a specific time. Just say 10 p.m. They have to give them a range. Say, I'll take the samples at 10 p.m. The lab will be informed that I'm taking the samples at 10 p.m. Prior to then. I take the samples at the hour of 10 p.m. So, but it doesn't have to be 10 p.m. on the dot, but within that hour of 10 p.m., you take your sample and send to the lab. Once you say that, they leave you be. That's what they want to hear most of the time. Yes, that's just my contribution. So you don't have to give them a range of time. Just say, you can just give them a specific time you do it. That's what they want to hear. Especially the old school examiners, that's what they want to hear. All right, thank you.
Thank you, sir, for coming in for clarifications and additions. Thank you very much, sir. I think the next presenter can start sharing the screen.
Okay, so I've sent my stuff to the page. I don't know if you can help me share. My phone does not support the sharing of the file.
Okay. Please, can anybody help? Dr. Dalhatu? Or anybody? Okay, Dr. Agu, go ahead, please.
Okay, good morning, everyone. I'll be taking the March 2024 practice question number 3A. So the question is a scenario of a 45-year-old man with current dyspepsia for many years, not responsible to PPIs. He had H. pylori eradication, triple and quadruple therapy, but multiple ulcers in the gastric antrum, duodenal bulb, and upper of the second part of the duodenum. No gastric tumor was seen. The questions: number one, what was the most likely diagnosis? I went for zollinger-ellison syndrome, the most likely diagnosis. And then differentials: retained gastric antrum syndrome, antral, then another differential of antral G-cell hyperplasia. The second question is, what is the pathophysiological basis of this patient's symptoms? Well, the symptoms of zollinger-ellison syndrome are secondary to hypergastrinemia, which now causes hypertrophy of the gastric mucosa, leading to increased number of parietal cells and consequential increase to maximal acid output. Gastrin by itself also stimulates acid secretion, resulting in increased basal acid secretion. The large quantity of acid produced leads to gastrointestinal mucosa ulceration. And this can also lead to diarrhea and malabsorption. The malabsorption of zollinger-ellison syndrome is usually multifactorial, being caused by direct mucosal damage by the acid. So in essence, the hypersecretion or hyperproduction of acid, gastric acid, which will be responsible for the multiple ulcers. Now, following the mucosal damage by the acid, there's also inactivation of pancreatic enzymes and precipitation of bile salts. Then the zollinger-ellison syndrome is sporadic in 75% of patients, whereas in the other 25% is associated with multiple endocrine neoplasia 1, an autosomal dominant condition characterized by hyperparathyroidism, pancreatic endocrine tumors, and pituitary tumors. Number 2 is organs that can be affected by this condition. Well, I put parathyroid gland, pancreatic endocrine, the pancreas, and then the pituitary gland, assuming that the patient has the type that is associated with MEN1 syndrome. Now, investigations to be carried out for the diagnosis apart from gastroscopy. Let me just plug my laptop. Okay, so the investigations that can be carried out include: one, the gastric pH levels can be assessed at a value of less than 2.0 in the presence of large gastric volume of greater than 140 ml over 1 hour. In a patient without prior gastric acid reducing surgeries is highly suggestive of zollinger-ellison syndrome. Then fasting serum gastrin levels, that serial measurement over several days, can also be used. Fasting chromogranin levels can also be assessed. Then secretin stimulation assessment test can also be done. The serum calcium levels can also be assessed. Elevation should prompt search for MEN1 syndrome. Gastric acid secretory test with gastric acid output greater than 15 milliequivalent per hour or greater than 5 in patients with prior vagotomy and partial gastrectomy is suggestive of ZES. Somatostatin receptor scintigraphy is the most sensitive imaging modality for the detection of primary or metastatic lesions of ZES. Thus is the imaging modality of choice in zollinger-ellison syndrome cases. Then CT scan can also be done. MRI imaging can also be done. List 3 treatment modalities. The first one is the medical care, which is aimed at controlling gastric acid hypersecretion. And once this is achieved, imaging should be carried out to localize and assess the extent of tumor. Intravenous PPI can be used like omeprazole, pantoprazole, IV pantoprazole. There's also room for surgical resection of gastric tumors. And then for patients with metastatic disease, chemotherapy, interferon, and octreotide may be helpful. Then for the patient that had an endoscopy, to improve the sensitivity of endoscopy, we could also combine the endoscopy with or those gastric ultrasonography. That could raise our chances of picking up tumors, because for our index patients, we didn't pick up any tumor with just the endoscopic investigation that we did for the patient. But if we could add an ultrasound to it, combine an endoscopic ultrasound with the procedure, that will raise the sensitivity of picking up tumor in this patient. So thank you. That's the end of my presentation. And no questions, clarifications, and contributions, especially in my choice of diagnosis, would be welcome. Thank you.
Thank you, Dr. Agu. Well done. It's time for contributions, comments. Any contribution, please? Okay. Attorney, who want to contribute? Go ahead, sir.
Thank you very much for this presentation. It's a nice one. And also, I think if you see the question very well, they said our proton pump inhibitors were given. So in the treatment, I think for you to say proton pump inhibitors, you have to say high dose proton pump inhibitors, because so that you go more specific.
Okay, sir. Thank you very much, sir. I'll add it to I'm just adding it to the slide now, so that I'll edit it.
So any more contribution? Okay, go ahead, sir. Doctor.
Yeah, well done for the good presentation. I think sometimes in the exam, you don't know that these questions will come out. So pathophysiology, when the pathophysiological basis that they actually wanted to hear was hypergastrinemia, leading to gastric hypertrophy, parietal cell hyperplasia, and then hyperacidity. In fact, the two keywords are the hypergastrinemia, hyperacidity. That if you mention, they will mark it. Most times in the exam, they don't want the detail of the way you talked about the pathophysiology now. They don't. If you're even going too much, you just say what is they want you to say the keywords. Those are the keywords that they will mark. So I think when we are reading for exams, let's pay attention to the keywords in especially when it comes to pathophysiology and stuff like that, because truly in the exam you will not, maybe the adrenaline of the exam, but the fact that you never really knew what would come out, so you could not have put all the detail of everything in your head. Even if you had all the detail in your head, by the time you want to put it out in the exam, it will not be as detailed. So you should always pay attention to the keywords. If you can't remember the detail in the exam, once you mention the keywords, they will mark it for you. I'm telling you, I mentioned hypergastrinemia. I said some other things, then hyperacidity. That was what they want. They just marked it and they moved on. So then the other organs I can affect, again, like I said, when you see this question in the exam, sometimes for example, this zollinger-ellison, I can't remember the last time I read it, possibly maybe 2018, 2019, thereabout. You know, it's not something that, because we don't see it as often, but it's something that if you read, it will stick because it's just classical. I mean, and once you see the question, it will just come to your mind that this cannot be PUD. Some people mention PUD, it couldn't be PUD again. This must be zollinger-ellison syndrome, you know. So of course you related it to MEN1, but you know, you could also say some other things. For example, I told them proximal, the other organs I can affect. I said proximal bowel, because I just didn't know what was in their marking scheme. I mean, so they said which part of the proximal bowel. So it means that it was part of, you know, it was part of their marking scheme. So I said duodenum. They marked it. I'm telling you, they marked it. Whether is it, well, they shall marked it. You know. So in case you are stuck in the exam when questions are asked, you may not. I mean, just go basic. Sometimes zollinger-ellison, we know, you know, stomach, duodenum, other part of GI. Just be specific, and then of course, you know, you can mention pancreas, pituitary, and all that. But I'm not even sure pituitary. I'm not sure, but maybe pancreas, because I mentioned that they ticked it. So whatever was in their marking scheme, I wouldn't know. But that was what happened in the exam. I'm not certain that they would take MRI. I'm not really certain. But gastric pH, fasting serum gastrin, I think calcium and secretin stimulation test, or what you could talk about. I think those ones are actually there. So yeah, so well done. But my contribution is just that we have to always pay attention to very specific words, you know, especially when it relates to pathophysiology. When we are reading in the exam, they will not document all the detail. They just want you to be mentioning the specifics. Thank you.
Thank you, sir.
Thank you very much, sir. I'll just edit it.
For this fatherly advice and contribution. Thank you very much, sir. More contributions, please. There is nothing from the chat box yet. If there is no, maybe I'll hand over to Chief Dr. Christabel.
Okay, thank you. Thank you, Dr. Yahaya.
Thank you.
Thank you so much. The two presenters did, particularly Dr. Ago. Thank you. Quite lucid, quite detailed. And I appreciate the comment from the facilitators, Dr. Tanimu, Success, Faisa, Aina, and many other persons, Dr. Allison, many other persons that contributed. I'm happy those that went Chief Chitu, many other persons that thank you. I love the way the new fellows are speaking up and trying to share their experiences and knowledge. Thank you so much. I appreciate it. These are things we love to see. Thank you. I think that's that. Thank you so much, Chief Chitu. This
Hello. Okay, good morning, Dr. Christabel.